In the meantime, I would like to thank Dr. Paul Nguyen for visiting us and sharing his experience treating patients and also in doing research. So our honor and privilege to have him here. And then we planned this talk. It's about something between 30 and 60 minutes. And also, this is going to be recorded. We already talked about that. If someone wants to review the talk, we will have that on internet. Will Science VR on YouTube. So we are going to have that for later for people that are now seeing patients or working on something, so that they might have opportunity to watch your talk. Oh, thank you for coming. And you have the perfect.
Thanks so much for having me, Leo. I really appreciate it. I appreciate everybody being here. I know that there are many things that people have to do, and it's a real honor and a joy to be here with you today. So what I want to talk about is utilizing clinical and genomic factors to optimize patient selection and reduce harm from androgen deprivation therapy, a very common medication that we give all of our patients with prostate cancer. These are my disclosures. And I must say, I was really excited to be here at Unicamp. I had such a joy to drive around with Leo and his family yesterday and see the whole campus. And I had a chance to look on Wikipedia last night. I was very impressed. This is the 2015 top university in Brazil, I hope you know, from the Ministry of Education, the 11th best university in the world of research universities under 50 years old. That's pretty awesome. And responsible, despite being here for 15% of the research in Brazil. It's amazing. More patents than any other research organization. That is really cool. So you should give yourselves a pat on the back. I think that's really fantastic. So I come from Harvard University up in Boston, Massachusetts, and I know some of you have had a chance to be there. And we usually have beautiful weather for 3 seasons of the year. So great in the spring, great in the summer, great in the fall. But unlike the great weather that you have here, we have a big problem in the winter. Thank you, Leo, with the snow. So this is 2 years ago. We had a big snowstorm, and there was no place to put the snow. So the snow. This is outside my hospitals. The snow plows just kept building it up and building it up, and there was this like wall, this mountain of snow. Those are real people down there. These are not fake people. These are real people, and so it was probably about. It was like 50 feet tall of snow, which was just crazy. And it leads us all to really do degrading things to ourselves in order to clear the snow. We have to put on like bird outfits to stay warm. So you have it good here. You have it good. And I really want to thank my host, Professor Race, for hosting me and giving me the opportunity to be here today. It's really, one of the great joys of academics is being able to make international collaborations and friendships like I have with Professor Race here. And it's really one of the great exchanges, really one of the great joys of being an academic. And I know that there are many students in the room, and I think that what you're pursuing is quite worthwhile, and you'll see that it'll pay off long beyond just the science that you do. It's also the kind of friendships you can make and the life you can have beyond it. So I'm going to summarize what I'm going to say, and that way, if you want to take a nap, that's fine. So I'm going to say ADT, or androgen deprivation therapy, causes a lot of problems, including psychological problems and possibly cardiovascular problems. And this is what I'll focus on, is the cardiovascular problems. And the second thing I want to say is that by combining both the genomic work and the clinical features, we can improve upon the D'Amico risk group classification scheme, also known as the NCCN risk group classification scheme. This is where we classify prostate cancer into low, intermediate, and high. I think we can do better using genomic factors. That's all I want to say. So now I'll take you through like 100 slides that say that. So you guys might know of Huggins and Hodges. So in 1941, they showed that castration, which somebody's about to do a castration here, right? I heard somebody, yes, Anna's going to do castration. So this induces dramatic responses in men with metastatic prostate cancer, so removing the testosterone. And for this, they won the Nobel Prize, or Huggins won the Nobel Prize in 1966. Now, you might say, what happened here? Because Huggins and Hodges did the work, but only Huggins won the Nobel Prize. So you have to be careful. What I tell my students is be careful. Don't let yourself be Hodges. Okay, something happened here where he missed out. So I'm sure Professor Race won't let you be Hodges. So thankfully, we don't have to castrate patients anymore. Modern hormone therapy is you can give a gonadotropin-releasing hormone agonist, or what I'll refer to as the GnRH agonist, such as leuprolide, and the androgen receptor antagonist. So we're not castrating men anymore, thankfully. Now, cure rates with radiation alone depend on the risk group. So we have low, intermediate, and high. Cure rates for low risk are 90%, but once you get into intermediate, high, and beyond, the cure rates go down a lot with radiation alone, and that's why we have to add hormone therapy. And multiple randomized trials have shown that adding hormone therapy improves overall survival, except in low-risk disease. You already have 90% cure rates. You don't need to add hormone therapy at that point. But for every other disease state, we add hormone therapy to improve the cure rate. But this led to a very widespread growth in the use of ADT for all risk groups. In the United States, we went from 5.4% use of ADT to 57% use of ADT, even in low risk where there's no benefit at all. In fact, when my father was diagnosed with prostate cancer in 2001, he had low risk prostate cancer. The first thing he got was a shot of Lupron immediately for castration. And overall, 75% of men with prostate cancer in the US were getting some kind of GnRH agonist. In fact, in 1999, this is the total amount of money that was spent on drugs in the United States, and this is the ranking of the top drugs that Medicare spent money on. Number one was Lupron. 15% of every dollar spent was spent on Lupron, and 8% was spent on Goserelin, which is another GnRH agonist. So combined, 23% of all of the spending on medications was spent on these GnRH agonists in the United States, which is a lot when you think about all the other drugs that we need to spend money on. So is there any downside to the ADT? Well, the answer is yes. There are the bothersome downsides, the hot flashes, fatigue, the loss of libido, gynecomastia, the testicles shrink, the penis gets shorter. And in fact, I had a student working for me. This was a research student who came to work for me. I think you guys have better projects than this, because I had a student came to work for me and said, I really need to do a research project. I want to do something very important. I said, okay, well, what you should do is you should see which treatment for prostate cancer leads to the most shortening in the length of the penis. And she found out that when you add hormone therapy, or if you do surgery, that leads to a little bit more complaints about shortened penis than without adding hormone therapy. So basically, hormone therapy does lead to a slight decrease, which is a bothersome side effect for men. We wound up doing a bunch of press releases on this, and it got a lot of attention. In fact, does anyone recognize Jay Leno? This is a comic on in TV in the United States. He wound up doing something about this story as well. So you can do research, and it can get all the way up to Jay Leno. Move this ahead. And there are other worrisome side effects. So people gain weight. There's more fat mass, more muscle loss, insulin resistance, triglycerides can increase, cholesterol can increase. You have a risk of fracture, possibly even a risk of Alzheimer's or depression, and we'll talk more about that. And patients don't often know the side effects of the ADT before they take it. This is the percent of patients who did not know that they were going to have these side effects before they took the medication. You can see for some of them, let's say increased risk of fracture. 60% of patients didn't know that they might have that. Or reduced muscle mass. 65% of patients don't know. So very few patients know about the side effects. They all know about hot flashes and loss of libido, but everything else they don't really know about. There were some studies that came out a couple of years ago asking about whether hormone therapy can worsen cognition. And this was one concerning study. It looked at 58 men at baseline and then 6 months and 12 months after starting ADT. And they found that the cognitive performance compared to the non-ADT controls was worse. So in blue, these are the patients who were taking ADT. In yellow, these are the patients who were not. And as you can see, this is the percent of patients who had cognitive dysfunction. And it increases over time in the blue, and then the blue over there. Whereas for those who are not getting ADT, actually the percent cognitive dysfunction decreases. Why is that? Probably because they are learning how to take the test. So they're actually getting better at taking the test. But this is real evidence that there may be some cognitive decline. Another study that was really worrisome, and it led to a lot of phone calls to offices, is this study that said that androgen deprivation therapy might increase the risk of Alzheimer's. This was a retrospective study. It was not a randomized trial in any way. It was just a retrospective study. But it showed that this is Alzheimer's-free survival, and the patients who were getting ADT were getting more episodes of Alzheimer's. In fact, the risk was almost doubled. It was 1.66. And this led to a lot of press. The Wall Street Journal, which is a big financial journal, said the study warns of Alzheimer's risk. It talked about effective treatment for prostate cancer doubling the risk of Alzheimer's. And people got scared of this. People don't want Alzheimer's, obviously. I try to tell my patients, you have to consider not just the total risk, so that not just the relative risk, which is the doubling, but you have to consider the absolute risk. So, the absolute risk was only 1% for 10 years. So if you take a look at this, this figure doesn't go from 0 to 100. This goes from 90% to 100%. And so the difference at 10 years, it's about 1%. So about 4% of patients got Alzheimer's with no ADT, and 5% got Alzheimer's with ADT. So even though it's called a doubling, because that's the relative risk, the absolute difference was only 1%. So I try to reassure patients it's not that bad. The other thing we have to consider with this data is it's not randomized. And what happens is, when you think about who to give ADT to, it tends to be the sicker patients. We give ADT to the patients who are sicker and older and more likely to develop Alzheimer's disease. So there's a little bit of confounding here, a little bit of bias that I think we have to be careful about. And this is our study. Our team did a study published in the JCO showing the association between hormone therapy with depression. And it kind of makes sense that patients who are exposed to hormone therapy will have an increased risk of depression. We're starting to recognize this risk more. Okay, let's talk now about the metabolic changes due to hormone therapy. So this is a healthy young man with big abdominal muscles here on the left, and this is an older man who's been exposed to hormone therapy, a lot more subcutaneous fat, a lot more atrophy of the muscles. You might know about metabolic syndrome, or syndrome X, which is central obesity, high blood pressure, high triglycerides, low HDL, and insulin resistance. Well, when you get ADT, ADT syndrome is very similar to metabolic syndrome. The only difference is that HDL cholesterol goes up. But otherwise, it's pretty much the same. You're doing the same thing to patients as metabolic syndrome. And so this makes us a little bit concerned. If you're causing the weight gain and you're causing all these metabolic problems, could you increase the risk of cardiovascular death? And this is something that really, I think in the late 2000s, really bothered people a lot. It made people very concerned. And these were the three pieces of data. Probably the most important one was this data from Keating. This was published in 2006 from the SEER Medicare data, which is a national registry of claims data, insurance data, basically. And this is what they found. They basically found that ADT for prostate cancer was associated with an increased risk of cardiovascular complications, specifically a 44% increased risk of diabetes, 16% increased risk of heart disease, 11% risk of myocardial infarction, and 16% risk of sudden cardiac death. All of these were statistically significant. Again, this was observational. This is not a randomized trial. This is just observational data. We know that sicker patients get hormone therapy, but this still scared a lot of people, and they tried to adjust for it. And this led to warnings from prominent groups about ADT and cardiovascular events. One, there was a consensus statement, which was multiple different societies getting together to say there might be a problem here. And the other was the FDA actually put out a warning, which is unprecedented about this issue. So this is what happened. We had the American Heart Association, the American Cancer Society, the American Urological Association, and the American Society for Radiation Oncology all getting together. Now, for those of you who know these specialties, it's not often that these specialties get together, including radiation oncologists and urologists, to agree about something. But they all agreed. They said, look, we looked at the data and we all agree. At this point, it is reasonable, on the basis of the above data, to say that there may be a relation between ADT and cardiovascular events and death. Everybody agreed. The whole scientific community agreed. And in fact, the FDA agreed too. They said, look, we've seen this data. Even though it's retrospective, we are worried enough. We're going to put a new labeling requirement on the GnRH agonist, and we're going to warn And you can hear the language. It's the same language from Nancy Keating's paper of an increased risk of diabetes and certain cardiovascular diseases, heart attack, sudden cardiac death, and stroke. They just took the language from Nancy Keating's paper and they made an FDA warning, which is interesting because it was retrospective. It wasn't a randomized trial. At the same time that all of this was going on, there was also data on the opposite side coming out. There were major studies showing no excess risk of cardiovascular disease due to ADT. There were randomized trials that randomized patients to hormones versus no hormones. And these two studies, when they reanalyzed for cardiovascular death, they found no difference in the risk of cardiovascular death. And there were other retrospective studies, not Nancy Keating's data, but other series, the Canadian registry, the CAPTURE registry from UCSF. And these both showed no increased risk of cardiovascular death. So how do you balance this data? You have actually 3 studies that showed an increased risk, and then these 4 studies that showed no increased risk. But the scientific community said, okay, there's an increased risk, we're going to put out a warning. Well, this is how I got very lucky with my career. Sometimes it's just like one paper at the right time leads to a whole bunch of other things. I was very bothered by this whole dilemma, and just on my computer, like my friend from Columbia who does meta-analyses, on my computer I tried to look for these trials that have randomized patients to ADT versus no ADT, because I thought, okay, we should look at the randomized data, and this will eliminate some of this confounding. And what do we find from the randomized data? So it was a very simple paper. I just pulled the data from PubMed. We looked at all the randomized trials that have randomized patients to ADT and no ADT, and we got very lucky that this was published in JAMA because it was the right question at the right time. And so for the students in the room, when you're thinking about the paper, or the kinds of projects you do, timing is very important, and you have to kind of think about what is the question that everybody's interested in right now. And I got lucky because the FDA was very interested in this question at that time. So we performed a meta-analysis of randomized trials to determine whether ADT causes excess cardiovascular death in men with unfavorable risk non-metastatic prostate cancer. We looked from 1966 to 2011 at PubMed, the Cochrane Central Register, and MBASE, and we wanted trials that were randomized. They had to have GnRH agonist-based ADT versus no ADT, so I wasn't looking for orchiectomy here. We were looking for cardiovascular deaths. We wanted a median follow-up of at least 1 year. And we didn't want metastatic disease, because when you have metastatic disease, you should just give the hormones. That's not the question there. If you have metastases, you need the hormones. So out of 1,041 records, it only came down to 8 trials, 4,000 patients. Median follow-up in the trials was 7.6 to 13 years. 5 trials had radiation, 1 trial had surgery, 2 trials had no local therapy, 3 trials were node positive, and the duration of hormones was less than 6 months in 3 trials, and then greater than 3 years in 5 trials. And these are the trials that kind of the famous international trials, Dana-Farber, ECOG, URTC, RTOG, and TROG. And this is the bottom line. When you look at the randomized data, there is no increased risk of cardiovascular death. The risk of cardiovascular death for the patients who were randomized to ADT was 11, and the risk of cardiovascular death for the men who were not randomized to ADT was 11.2. So even though there was all this signal from retrospective data, the randomized data didn't show any difference. And in fact, the relative risk was 0.93, and the p-value was 0.41, really suggesting no difference. These are the forest plots. So if you look at each randomized trial, this is 1 here. That means there's no difference. That's the dotted line. And for every single trial, none of the trials actually found an increased risk of cardiovascular death. And when you put them all together, there's no increased risk of cardiovascular death in the summation of the trials. The results were the same in all the subgroups. Didn't matter if you had short course or long course hormones. Didn't matter if you looked at trials with men over age 70 or trials using radiation. And I think this is why we got the paper into JAMA, was because we also reminded people that hormone therapy reduces prostate cancer death and also reduces all-cause mortality. Remember back in 1941, they found that. And I think that all the scare about hormone therapy and heart disease really scared people away from taking hormone therapy. And here we had to remind people, hey, let's not forget this drug saves lives, and let's not get scared. So it reduces prostate cancer death by 31%, reduces all-cause mortality by 14%. And these are the forest plots. If you look at the individual curves for prostate mortality, a lot of the trials show a benefit, so the overall summary shows a benefit. And same with overall survival. A lot of the trials show a benefit, so the overall shows a net benefit. And so in conclusion, based on this, ADT appears to reduce prostate cancer mortality and improve overall survival for men with unfavorable risk prostate cancer without causing excess cardiovascular mortality. So this may be very popular with some of our friends at AstraZeneca and Watson Pharmaceuticals. They were very happy that prostate cancer drugs aren't tied to heart attacks. I also was very pleased I had an opportunity to pose for this interview here. I got my photo taken for Men's Health to talk about New Hope for Prostate Cancer, so that was a very nice opportunity as a researcher for me. Okay, so is this the end of the story? Is that it? So there was retrospective data, and then I did one meta-analysis, and then the whole story's over. No, that's right. That's right. So as it turns out, there is a lot of data still emerging on the other side from retrospective research. So this was a meta-analysis that came out 4 years later. And it was by a group at the UK. And they looked at observational evidence for the risk of fatal and non-fatal cardiovascular disease following androgen deprivation therapy. And here's what they found. Basically, if you look at all of the observational studies that are out there, you put them all together, there's still a very strong signal that hormone therapy causes increased cardiovascular events. So here, the pooled hazard ratio was 1.57. Every single study that's been published, Keating's paper, other Keating paper, Van Hemmelrich paper, they all show an increased risk of death with a significant pooled hazard ratio. Not death, but myocardial infarction. And they show an increased risk of fatal or non-fatal stroke. And the pooled hazard ratio was 1.51. So all of these are statistically significant, and they're all from the retrospective data. So what do we do? How do we put this together? What can explain the discrepancy between the randomized data and the observational data? Remember, the randomized data shows a hazard ratio of 0.93, no difference, but the observational data shows a very strong increased risk with a hazard ratio of 1.57. So what's going on here? I think there are three possible explanations. I think number one is maybe the most boring explanation. It might be true, but it's the most boring one. It might be that the results from the observational data simply reflect confounding. That we give sicker patients hormone therapy. These are the patients who are older and have more problems, and they're not healthy enough to get on Professor Race's operating table, and so we just give them some hormone therapy. So these patients, of course, they appear to have more cardiovascular death. That's a simple answer. I think some of that is true, but I don't think that's the whole explanation. The other possible answer is that the observational results only included non-fatal MIs. So that meta-analysis was actually for non-fatal MIs, whereas the randomized data looked at cardiovascular death, meaning it might be possible that hormone therapy increases the risk of non-fatal MIs, and then you don't actually die from them. And that's why we can have randomized data that says no difference in death, but non-randomized data saying that there's an increase in events. But I think the last one is the most interesting, and I hope that the last one is true. It might be that ADT causes harm mainly in men who already have some pre-existing comorbidities, that these might be the sick men, this small subgroup of men who are sick. And these men tend to be underrepresented in randomized trials. When you think about who do you put on a trial, there's so many exclusion criteria for trials. They can't have hypertension, they can't have this, they can't have had a stroke, they can't have had that. So the patients on randomized trials are healthy patients. They're different from the observational pool that we look at. And here's the evidence. There should be some evidence if you have a hypothesis. So here's the evidence that there might be a subgroup of men who could be harmed by ADT. This is a trial run by my mentor, Dr. D'Amico, and it's an old trial. It randomized patients to 6 months of hormones versus 0 hormones. And it found that after 16 years of follow-up, ADT does not anymore significantly improve overall survival, possibly because of the harms that ADT might be doing in some men. But here's what was really interesting about this study. So the overall trial is negative, but if you make subgroups of the trial, On the left are the healthy men. These are the men who are very healthy and they have no medical problems. On the right are the men who have a lot of medical comorbidities. Maybe they've had a heart attack before, maybe they've had congestive heart failure before. The benefit of androgen deprivation therapy is completely different. So if you look at the men on the left who are healthy, there's a very big benefit to androgen deprivation therapy. These are the patients that got ADT, these are the patients that did not get ADT. This is overall survival. These patients that got ADT lived much longer if they were healthy. On the right, these are the patients who are sick. They have other comorbidities, and here the curves are flipped. Actually, this is randomized data now. The patients who got ADT actually had worse survival. It wasn't quite statistically significant, but it certainly suggested that there could be a problem, a differential effect in patients who are healthy versus patients who are not healthy. The criticism of this is that it's very tiny numbers. The whole trial was 200 patients. The healthy men was 149 patients. The sick men was only 49 patients, so it was a tiny, tiny, tiny trial. But it's the only evidence we have. If you look here at the patients who have moderate or severe comorbidity, out of 24 patients randomized to radiation and hormones, 15 died of cardiac reasons. Whereas of the patients who were randomized to radiation alone, out of 25, only 6 died from cardiac reasons. The hazard ratio was 0.17, meaning that these patients without hormones were much less likely to die of cardiac reasons. And the p-value is very statistically significant. The criticism is this is only 21 deaths. So how can you make a grand statement based on 21 deaths? We can't. It's not fair. But at least this is the evidence that there might be this effect going on. That maybe for most patients, hormone therapy is safe. But for that small minority of patients who are sick and have other comorbidities, hormone therapy can potentially cause a lot of harm. Okay. And this is other evidence. There's another paper that came out in JCO last year suggesting that it's this group that had prior to recent cardiovascular events, this group that has the highest rate of ADT-related cardiovascular events. So it's more evidence in this direction. There's some questions about what specific comorbidities might place men at highest risk of harm. And basically this study suggested that, this is retrospective, so it's not as good data, but suggested that it might be CHF or MI, that these patients who have had a prior myocardial infarction or prior congestive heart failure who are the most dangerous. So in terms of decision making in the clinic, I think the way I try to think about it is we have to balance two factors. One is how aggressive is the prostate cancer, and the other is how sick is the patient. So this is what we have to balance when we decide whether or not to give ADT. As you go from low risk to intermediate risk to high risk to node positive, the risk of prostate cancer death increases, so it is better to give ADT. On the other hand, on this side, as the comorbidity level increases from no comorbidity to single comorbidity to the worst, which I think is a CHF or a prior MI, you start to worry about not giving ADT. And I think it's easy to make these decisions at the edges. So if you have low risk disease and you have a history of CHF or MI, of course you won't give ADT. Or if you have very bad disease and you have no comorbidity, of course you'll give ADT. But the question is really more in the middle. What do you do for a high risk patient who has some comorbidity? What do you do for an intermediate risk patient who has a little bit of comorbidity? This is where the art of medicine really comes in, to figure out how to balance out these two considerations. And I think we're all still trying to figure that out now. So next thing I want to talk about is part 2, which is, can we refine patient selection for ADT by using some genomic information to improve upon the current D'Amico risk groups? So I think you might have all heard of the D'Amico risk groups. This is low risk, intermediate risk, and high risk prostate cancer. So this was a teacher of mine who figured out how to divide prostate cancer into low risk for death, intermediate risk for death, or high risk for death, so that we could treat these patients a little bit differently. And these D'Amico risk groups are actually used around the world. He actually is a radiation oncologist, but was able to produce these groups. It's really cool that pretty much everyone uses. In case you haven't met him, you've probably seen him at meetings. This is his picture. He's very, he speaks really well. He wears beautiful suits. He's a very formal guy, but I love him. He's been a wonderful teacher to me, and he shared with me some other pictures from his youth. So here are some other pictures of Dr. D'Amico from many years ago. So this is what it takes to put together these kinds of risk groups, is this kind of fortitude. He actually can have a car drive over him. I know Leo, you like cars, but I don't know if any of us has ever had a car drive over us like this. So this is what it takes to make those kinds of risk groups. Okay, so the question here is, can we use genomic information first from biopsies to help risk stratify? So we have been very good now. A lot of tests have been developed to use genomic information from prostatectomy samples. Because as a urologist, when you take these out, there's a lot of tumor, and we're able to analyze that pretty well. But what we don't know is whether we can take it from biopsy. So this is some work that I did with several colleagues, which is to look and see whether you could take the Decipher prostate cancer classifier, which has been developed on radical prostatectomy specimens, and use it on biopsy samples to predict who's going to die of prostate cancer. So we presented this year at the ASCO GU, and it's been published in European Urology. So Decipher is a 22-feature RNA-based signature developed to predict the risk of metastasis after radical prostatectomy. And it looks at cell cycle proliferation, adhesion and motility, immune modulation, and androgen signaling. So these are the markers that are put into this. And typically this test is done here. So people have a biopsy, then they have a risk assessment, they decide whether to have active surveillance, radiation, or prostatectomy. And then after prostatectomy, they would have a Decipher test to figure out if they will get adjuvant or salvage treatment. But the goal of this study was to figure out, well, can we use the Decipher test here after the biopsy to try to figure out what treatment should the patient get? And so that's what we did. We evaluated the Decipher genomic classifier to figure out if you could predict for metastasis and prostate cancer death among patients treated with both prostatectomy and radiation. This was a cohort that included Dana-Farber, where I'm from, Cleveland Clinic, and Johns Hopkins. It had some low-risk, intermediate, and high-risk patients. There were 32 metastases and 11 deaths. And here's the bottom line. You could use the Decipher classifier based on these biopsy specimens to predict the risk of metastasis. So there's a low-risk group, an intermediate risk group, and a high-risk group. So you could use this to predict metastasis. And it also predicted death. So you could use this to predict who's going to die from prostate cancer. Based on the 11 deaths, on univariable analysis, the Decipher, used based on the biopsy, was the only factor associated with death. The hazard ratio was 1.57 per 10% increase, and it was statistically significant with the p-value of 0.02. Okay. So this was the conclusion from this study, is basically, okay, we can take the biopsy tissue and we can run this test and we can use it to help predict who's going to die of prostate cancer. The next study is, can we actually take that genomic information and combine it with the clinical information from the D'Amico risk groups, which we've been using now for 20 years. D'Amico risk groups were established in 1998. Can we take that 20-year-old classification system and use the genomic information and put them together to make a risk group system that's even better? And that's what this was. This was presented this year at the ASTRO meeting. This was led by Dr. Daniel Spratt at the University of Michigan. He was very kind to have me as a senior author, and this was just accepted to the Journal of Clinical Oncology, so this will be coming out just in a few months. So this is like an early release for you. But basically the idea was, can you develop and validate a novel clinical genomic risk group classification for prostate cancer, incorporating the genomic and the clinical pathologic risk? So this is the D'Amico risk group. D'Amico risk group has been divided now into actually 4 risk groups. So there's low, and then intermediate was divided into favorable intermediate and unfavorable intermediate, and then there's high. And this is how it splits out in terms of metastasis. Actually, the low and the favorable intermediate perform very similarly, and then the high and unfavorable intermediate perform very similarly. Which is okay, But ideally, I think we'd like to have a group that's a very high risk group, so we know what to do with them. We'd like to have a low group that's very low, and then an intermediate group that's right in between. And so this is what Dr. Spratt did to try to put together clinical and genomic features into a single clinical genomic risk group. He made a score. He said, okay, the NCCN risk group is going to be a score, so NCCN is the same as the D'Amico risk group. So if you're low, you're going to be 0, favorable intermediate, it's 1, unfavorable intermediate, it's 2, and if you're high, it's going to be 3. And then you're going to add to that the genomic information. If it's genomic low, it's 0 points, genomic intermediate, it's 1 point, and then if it's high, then it's 2 points. And then you're going to put those together, add them up, and then make a new risk group. So if you have a total of 0 to 1 points, you're going to be clinical genomic low. If you have 2 to 3 points, it's going to be clinical genomic intermediate. And then 4 to 5 points, it's clinical genomic high. Putting together both the biopsy information from the genomics and the clinical data. And this is how it looked. Essentially, when you look at the clinical genomic low, it's a very low risk group. Intermediate is quite intermediate. And the high is a very high risk group of metastasis. This is a group that has nearly a 60% chance of developing metastases by 12 years after treatment, which is a very, very unfavorable group. This is higher than the standard high-risk patients. These are really very high-risk patients who are going to develop metastases at such a high rate after treatment. And you can see the low risk is doing very well. They have almost a 0% risk of death, meaning that it's a very good low-risk group. This was the validation cohort. This is perfectly what you would hope to see. The low risk has a 0% risk of metastasis, whereas the high risk has almost a 60% risk of metastasis. And so you can see that by using the genomic data, you can make the low very low, and you can make the high very high. And it performed better than just using the genomic risk groups alone. So this is the genomic risk groups by themselves: genomic low, genomic intermediate, and genomic high. And this is the combined clinical genomic low, intermediate, and high. And you can see that the clinical information also adds to the genomic information. Because if you just use the genomic information and you look at the low risk, some of the low risk will metastasize. And so you might misclassify some of the low risk if you just use the genomic information. But if you combine the clinical and genomic, you get it here in this case perfectly. Nobody with clinical and genomic low develops metastasis. So it's a better system. And it turns out that this is the C-index for metastasis. If you use the clinical data alone, the C-index, which means the area under the curve for predicting metastasis, is okay. It goes from 0.62 to 0.68, but you can really improve it a lot to 0.75 to 0.85 using the genomic information. So, to take it back to the beginning again, in summary, I hope you've heard that ADT causes a lot of problems, including psychological and possibly cardiovascular problems. I think ultimately it probably causes cardiovascular death in a small subgroup of patients who have a lot of underlying comorbidity. And by combining the clinical and genomic features, we can improve upon the D'Amico and NCCN risk group scheme. If we have a minute, I'm going to just share one more thing because we have some trainees in the room here. This is a paper that we did. It was published in the JCO in 2013. It was looking at marital status and survival in patients with cancer. This is not usually what we talk about, but it's kind of an interesting study. It got a lot of press because it's an easy study to understand. I wound up on national television, talking on NBC, this and that. It was first authored by Dr. A.L. Azer, who's just a wonderful radiation oncologist, and he does a lot of great database work. But basically what he found is that compared to unmarried patients, married patients were 17% less likely to have metastatic disease, 53% more likely to receive appropriate therapy, and 20% less likely to die of their prostate cancer. I personally don't think that it's marital status by itself. I think this is a proxy for just having more social support in your life so that you can get the kind of cancer therapy you need. And if you look at the agents that improve survival in metastatic prostate cancer, I'm sorry, I know there's some representation from Astellas here. We can say, look, at least the Astellas drug enzalutamide had the best hazard ratio for death. It was the best. It was 0.63 when you look at the metastatic setting. And then other drugs like sipuleucel T, this drug costs $100,000 per cycle. Docetaxel is cheap, but sipuleucel T is expensive, and its hazard ratio is 0.79. Well, as it turns out, social support, whereby marriage is a proxy, has a hazard ratio of 0.74 for death in prostate cancer, suggesting that it's not enough to just have the best science. And I know here at Unicamp you're working on making the best science. We also have to think about how do we translate the best science and get it to the patient. There's a lot of gap between the best science that you have here, and you're all making the best science, versus what the patient in the community setting actually receives. And so there's a big gap there, and you have to think about that as you're training and going through what are you going to focus your career on. Don't forget that gap as well, that we can't just come up with the best science, we have to actually implement it and get it out there. And this is what the like the telecom, like the cell phone companies call the last mile problem, which is, it's not so relevant now because we all have cell phones now, but back then, these phone companies would create the best networks, and they'd be very strong, and they could do that very well. But it cost them a lot of money to run that last wire, that last mile to get to the end user. And so it's a very similar problem we have in science now. We can create the best science. We have the internet, we can make collaborations. You will make the best science here. But there's still work to be done to get it to that patient over there. This is November, so I know there's a blue November thing going on here to support prostate cancer. This raised almost $1 billion now for prostate and testicular cancer. I participated in this as well, so I'm starting to grow now. I tried not to do it for respect for Leo's family, so they didn't have to see me like this, but soon I will do it. And this is, I like to wear this hat sometimes, but my wife doesn't like it because if you've ever seen the movie Austin Powers, she thinks it looks too much like the mask in the Austin Powers movie. So, so good. Well, listen, thanks very much, everybody, for...
I think we have space for time for a few questions, and for me it's really an honor and a privilege to have you here. I've been discovered that you are a special man, and also this impacts how you understand science and how you communicate science and patient care. So I'm really impressed with your characteristics that are very important and not so common. I would say rare, and not in Brazil, but if you go around, it's hard to see someone like Professor Paul Nguyen. So I'm glad we are connected and we are, I can say, friends, because we and I say myself are learning a lot with you. Thank you very much for everything. So one question I have is, do you think that using genomic data we are so good that there is a few things to improve, or how much in terms of potential we still have to improve? My question comes because I feel, and we are looking for that and studying this aspect. That means there is a gap between genomics and for example, phenotype, and we should fill this gap. It may be the distance between what we got in terms of improvement and what would be the best scenario possible should be related to the gap between genomic and phenotype.
Yes.
So then I would like to hear from you how much you think we have in this room or in this gap. Is that big enough to look at that with more enthusiasm,
yeah.
Or there is there, yes, you agree or not? If you agree, yes, there is a gap, but this gap is not so big, so then the enthusiasm should be not that big, because still we have a gap, but not
Yeah.
too big. So that's something I would like to hear from you.
I think it's a great question, and I think for those in the room that are in Professor Reyes' lab, you should continue to be extremely enthusiastic about closing that gap, because the gap is still big. And I'll show you, it's right here. This is the best that we could do today, is to put together an expensive genomic test and put that together with clinical data. And the best we were able to get in terms of predicting metastasis was an area under the curve of 0.75 to maybe 0.85. I think it's fair to say this one's an outlier here. And so maybe it's more around here, around 0.75. But there's still a lot to go, meaning that there's still going to be patients where you put together the best current clinical data and the best current genomic data. This, we need to get to 100%. It can't be 0.75. You can't tell a patient, we have a 0.75 chance, or it's not the same as a chance, so I shouldn't say it like that. But there's still room on the table here. That for patients who are going to bet their life on this, there's still a lot more room to improve. So I do think there's more room, a lot more room.
May I have a question?
Yes, sir.
When you have a patient within this situation of high risk by the combination with the clinical and genomic,
Yeah.
and the patient has a little cardiovascular problem.
Yeah.
How do you manage it for how long time the AGT?
Yeah. I think it's a great question. So the question is, it gets back to this, like, how do we balance out when somebody has high-risk disease, but they also have some cardiovascular disease? Where's that fine balance that comes in? And where I think there might be some option is to potentially reduce the duration of hormone therapy from 2 years to something less. So instead of being so strict in saying, okay, if you have high-risk disease, you have to give 2 years of hormone therapy because that's what the guidelines say. Maybe if you have high-risk disease and some cardiovascular disease, maybe we can reduce it to 18 months. I think 18 months is very reasonable. There's a lot of data for that. Or you could even potentially reduce it if they have a lot of disease to 6 months. Because I think the biggest benefit from the hormone therapy comes in the first 6 months. That the biggest benefit is 6 months, and then after that, the benefit is a little bit less.
And do you use the radiation escalation dose for this type of patient by using only 6 months, for example?
Yeah, I think if you're going to use 6 months, then I think we should do what your specialty is, which is brachytherapy, and add brachytherapy boosts to these patients so that at least you're giving a lot of dose down here if you're only giving 6 months of hormones. That's what I do. How have you been doing that?
Yes,
Is that
yes.
Similar, yeah. Any other questions from the room?
You touched a sensitive point here, that is the last mile or the last piece of road to get to the patients. And that's really important and really the most difficult point. And in that scenario, we have discussed what can we do once the money is not it's limited everywhere. You can have more or less, but always it finishes. So then we were discussing, for example, how much surgical castration can be as good as pharmacological castration once they get the same strategy. And how this is myself thinking, how could we, for example, if we can save money with surgical castration, how that could impact on the chances we have to offer more new and treatments that are obviously more expensive today because it costs money to develop some new drugs.
Yeah.
and then that explains part of the costs.
Yeah.
Not necessarily related to the production of a drug, but the development of a drug.
Yeah.
And then I came with the idea, and I'm planning to write something about that. There is some controversy in that, and many maybe we'll fight against different interests, but at the end, I'm thinking about how much we can offer better treatment to our patients if we offer them castration, surgical castration, and save money for very new drugs that can really make a difference compared to the old armament, old tools we have for the last couple of years, or 10 or 20 years.
Yeah.
How you see this kind of brainstorm?
Yeah. It's a very interesting question, because we had a paper, the senior author was Kwok Trin in my group as a urologist, where he compared surgical castration versus the GnRH agonist that we've been talking about, medical castration, in terms of side effects. And for some side effects, he found that the surgical castration is better. And it might be that the GnRH agonist itself is causing some of these side effects. There's something about the formulation of the GnRH agonist that leads to more side effects. So if orchiectomy has less side effects and it's cheaper, then maybe we should be thinking about it in certain subsets of patients. Now, and so, of course, we wrote that, and the editors pushed back and said, well, you have to be careful about which patients. So, of course, if you're thinking about just doing 6 months of hormones, then we shouldn't do an orchiectomy, because we don't want to give lifelong castration to somebody who needs just 6 months of hormones. But as Professor Reyes is saying, like, if you're thinking about somebody who has widespread metastatic disease and they have to be on hormones for the rest of their life, then it's much cheaper to do a castration, maybe more effective. There is the cosmetic issue. A lot of men, bothers them mentally, or the cosmetic issue. So I wondered, can you put in little like prosthetic testicles or things like that, so that can help with that? But I think it makes a lot of sense for men with metastatic disease to think about it. How about here in Brazil? Like, do you ever do castration for metastatic disease, or
Yes,
still mostly medical?
we usually do. In the past, we used to offer more surgical castration, but as always, when you have different options, we have also the pressure of patients and the market. So then I think that is the cause of the decrease we had in the surgical castration. Myself, if I'm a patient like that has incurable disease, as you told, I would prefer surgical castration, because I can say it's safer, your treatment is warranted, so you don't need to wait and see. Will you have the drug to
Yeah.
and many other aspects? So that's safer in terms of you are treated. That's one shot and everything's done, and cheaper. So myself, I think that for myself I would choose that thing. And also we have small studies looking at the possibility of reversal quit of castration. That means giving them testosterone. If you castrate, you can give testosterone. We have many patients that had testicular issues, like orchitis, that they don't have testicles that are working well, so they get testosterone every month or every 3 months to keep their hormonal or testosterone function. So they would be similar to those patients that do very well in case they need. And I don't think that most patients would need any level of testosterone that it comes from outside, like this kind of treatment. So I really think we should discuss more these aspects. And what do you think might impede or might we work against in terms of making that true, making that practice to give to our patients more reasonable tools? That means we don't want to shot a net with a big shot, and then when it comes a big animal, you have a small shot. So if I made myself clear,
Yeah.
so I feel sometimes that we are losing our big shot for a small
Yeah,
thing,
yeah.
and then we run out of resources for when we really need.
Yeah.
How you see that, and how you think, because I can answer myself. We are trying to teach our doctors and how this can be important in a system like ours.
Yes.
And maybe for every 10 or 50 patients that you save money offering surgical castration, you can treat one patient with new drugs.
Yeah, I totally agree, and I think that this issue is starting to push around the United States and Europe as well. Like, as these papers come out that say that surgical castration may be better than a GnRH agonist, this debate is coming back. I mean, I think that surgical castration kind of went away once the GnRH agonist came out, but I think now we're starting to talk in that direction again. And of course we have to get over, I think men have a lot of sort of, mentally they don't like the idea. At least a drug is a drug, but like actually surgical castration is very difficult for men sometimes, so I think we're still gonna have to get over that. I think that's kind of where we're at. I know my friend from Colombia had a comment or wanted to say something about this as well.
Not about this, I have a question. Thanks a lot for this wonderful talk. And I wanted to ask, what do you think about using this kind of genomic tests and some other different tests, costly tests,
Yes.
in Colombia or in developing countries?
Yeah.
It's really difficult for us
Yeah.
to have access to
I
tests
hear
like
you.
this.
I totally hear you. What I think is going to have to happen is that as these tests become used more widely in the United States and in Europe, it'll allow the companies to do the tests at a lower cost. I think as they get more scale, because right now the companies, a lot of them are sort of new companies, and so they have to pay back all the investment they put in up front. But as the technology gets better, the cost can go down, and I think it can become a more widespread used. So I think we have to start. This is just the start. So I think it's the beginning, but we have a long way to go to get it. It's again also the part of the last mile problem. But it's a good question.
Still about that.
Yes.
I'd hate to be the devil's.
The devil's
Advocate.
advocate.
Yes,
Yes.
but by that point, wouldn't you say probably the technology in other countries will develop something even better, even more accurate than what's there today? So probably
Yes.
they would still, or we would still be backwards. I mean, we wouldn't be there in the top technology point as the others. So yeah,
Yeah, I think it's a
still
good point. It's a difficult dilemma.
Yeah, yeah.
It is a difficult dilemma.
Just another quick question. How do you like the idea of tumor avatars to search for the tumor sensitivity or tumor phenotype? Because we have a student that is working on that right now. We are trying to fill the gap between genomic and the phenotype. So one strategy to that is to use a tumor avatar or patient-derived tumor tissue to learn about the behavior when exposed to different drugs. So then we can move to a more individualized treatment.
Yeah.
In a similar manner of that we can do with genomics, but also trying to decrease the costs, number one, and number two, fill the gap of between genomics and the phenotype. How you like that idea? How you think this can be something, or you have a different strategy for this rationale? I mean, what comes after? You showed us very well that maybe genomic is something that is for now and for the short time future, like we won't take long to have genotype in every place, in many places, but what comes after?
Yeah. I'm smiling because I'm so excited by this concept of the avatar, like the kind of stuff that you guys are doing. I mean, I think that's incredible. I'm a very simple person. I'm a simple radiation oncologist, and you know, I do things with data and databases and things, but I'm not a scientist. I'm not a scientist. I can take the data and try to manipulate it and do things and try to ask the questions, but the science that you're talking about it gets my heart beating fast because it's so exciting. Because that's really where the cures will happen. Like, you know, I think that the kind of work that I do can help us to understand where the data is and what's going on, but it takes people in the lab, like here, to actually move things forward and make those quantum leaps. We can describe it, we can put it into terms that people can understand, but we need the science that's going on here to move things forward. That makes my heart beat fast to think about you're making tumor avatars and you're going to be able to use these on people. I love it. So I'm not qualified to tell you, you know, what's the right path or what's the wrong path, but to me that's so exciting.
Thank you very much. I think one last quick question, or we can finish. Giovanni would like to make a question or comment or something?
No, just to say a big thank you for you and showed all this data, especially the last reference that you show us. That's very new for in the scientific scenario. Thank you very much.
It's my pleasure.
So maybe you are referring to when we have a strong support, and that's family playing a role there. That's quite everything. So that's maybe a lesson for all of us to take to give the value that this aspect really has in your life. What you can say? Do you agree?
Absolutely. I mean, I think it's something very simple. Like, if you have family support, then someone will take you to the appointment. Someone will make sure that you're going to the doctor. You know what it's like to have your wife tell you, "Did you get things checked out? Is everything, you know?" Whereas, and it's not about just your wife. It's about having friends and people that support you that can actually get you to appointments and get you the kind of care that you need. And the message that I gave on TV was that this is a good news message. It's not bad news. It's not that unmarried patients are going to die. It's a good news message. It's that every single person can give help to their friend with cancer. That if your friend gets diagnosed with cancer, you can make a difference. You can help them go to their appointment. You can make sure they're getting the treatment they need. You can be the voice there that kind of listens. So it's a good news story. It's not a bad news story. And I'm sorry I didn't get to your question.
Have you had the chance to work with the other omic sciences like metabolomics or proteomics or all other sciences? Have you had the chance to work with that kind of data in order to treat patients with prostate cancer?
So I have not personally. For me, I've just kind of tried to get into this whole RNA affymetrics thing, and that's kind of where I invested. I think if I was a scientist, I could be a little bit broader, and I'd like to move there slowly. But for me, it's a little bit one step at a time. So I'm not there yet, but personally.
Dr. Paul,
Yes.
do you think that that some information that you show us about the genomic alteration that you're mixing with the micro categories, do you think that these new parameters will be shown soon in guidelines, or do you think there will be a new criteria to make this stratification of different cancer types?
I hope so, because it's going to be published in JCO. On the other hand, it only used one of the available genomic classifiers. So we have the Decipher classifier, the Myriad classifier, Genomic Health classifier. So there are 3 of them that are FDA available. So we only use this one. And so will the guidelines adopt that? I'm not sure. I'm not sure if they will. Or it might always be a little bit outside the guidelines. Or maybe they'll say, hey, refer to this paper. If you use the Decipher classifier, you can use those guidelines. So, cross-reference, exactly. It would be nice.
You told about making sure the patient will not miss the appointment, and many other aspects related to the support, related to the family. But maybe the fact that you might have someone by your side might count also. Not really not missing the appointments, but being happy, inside, feeling safe because someone is with you. So discomfort cannot be replaced with any kind of drug or modern treatment. So at the end, my feeling is now we are more going far from the science, but we are humans and we have feelings, and my impression, it's not evidence-based, is that this kind of feeling will it's hard to replace that with any modern tool or whatever. And this is also a piece of this thing when you say of this aspect, that when you say not missing an appointment and things like that.
I think you're right, and in fact in the discussion to that paper, because we had to come up with some scientific explanation too, it can't just be social. When you look at married patients and you test their cortisol levels are lower in married patients versus unmarried, even before and after. So good studies have been done on this kinds of things. So there's some biochemical difference too, I think, that has to do with that as well. So there's some science to it as well, I think, beyond just the social report.
Thank you very much. I would like to thank every one of you that came to see this wonderful presentation. I'm not so young, but one of the best talks I ever.
Thank you so much. Thank you for your friendship, Leo.
Thank you very much.
Glad to be here. It's a
So,
great.
with that, we can finish. Thank you again.
Thank you.
Hope we
Thanks
can
everyone for listening.
have you again with us soon.
It would be a pleasure.
Thank you very much.
Thank you.
Thank you.
Nice to see you again.